Share my screen here. Okay, so prenatal screening. We talked about antepartum last time and learned about pregnancy anatomy. Now we're going to learn about what we do to make sure that that pregnancy is doing okay and growing according to the way we like. In the first 5 to 8 weeks of pregnancy, they're going to have their first appointment with their provider. And in this appointment, we will review their history, including their GT-PAL. We'll confirm a positive pregnancy by either doing an ultrasound, which is really what we do, or if it's past 9 weeks, we could probably get some fetal heart tones on a Doppler. At that point, we won't be able to feel the baby move at 5 to 8 weeks, but remember, that's another way that we could confirm a positive pregnancy is fetal movement by a healthcare provider is stated. Around 20 weeks is when the mama will start to feel baby move. Most people anyway. Sometimes people can feel it a little bit earlier, but most people around 20 weeks can feel that baby move. We'll do some blood testing. The first one we would do is called an indirect Coombs test. The Coombs test finds antibodies that could bind to the red blood cells and possibly attack the baby's blood. So we're going to test to make sure that those antibodies are not present. And then we also repeat it at 28 weeks. And if it comes back positive, we're going to give RhoGAM. RhoGAM is a blood product, and it's used to make those antibodies not attack the fetal blood. Okay, there's a video at the end of this slide deck that explains it a little bit more in depth about what we're looking at. We're going to give them an estimated due date in this first visit using Nagel's rule or a pregnancy wheel, which in lab you guys will get to see and play with to determine what the gestational age is or the estimated due date. On the wheel, we would just put in their last menstrual period date, and then it would give us an estimated due date. We'll also do fetal measurements on the ultrasound and measure the fetus to see if that due date matches up. This is the most accurate time is in this first 5 to 8 weeks to determine a due date based off of fetal measurements. We'll also offer that genetic carrier screening if they didn't get it done in the pre-pregnancy period. Testing for the big ones mostly, sickle cell, cystic fibrosis, Tay-Sachs, and if they have any family history of genetic disorders, we can test for specific ones, or we could just do the whole panel of however many hundreds they end up doing. In the first trimester, we'll also do, probably at this same visit, we'll do a blood type. We'll get her blood type and RH factor because that becomes important, which we'll learn about again at the end of the slide deck. We're going to test her glucose, the glucose in her blood, iron and hemoglobin levels. Check for rubella immunity. If she is non-immune, she'll get the MMR vaccine after she delivers. We can't give that one during pregnancy, but it'll be on our radar. We'll check for STIs, hepatitis C and B, and then also toxoplasmosis. Toxoplasmosis can be passed in cat fecal material, and so women who are pregnant should never change or clean a litter box if they own a cat. Around week 10, we're going to do another blood test called an NIPT, non-invasive prenatal testing. This test will determine whether or not we have a risk for genetic anomalies in this baby. So if that comes back abnormal, then we're going to do invasive testing to confirm if there's any chromosomal abnormalities in that fetus, which we'll talk about coming up too. Weeks 11 through 14, we're also going to assess the risk of Down syndrome if we didn't get that NIPT testing done. Via ultrasound. Actually, even if we do it, we still do it via ultrasound. By looking at the neck of the fetus, looking for, it's called nuchal translucency. And that would also determine whether we had a risk of a chromosomal anomaly as well. If we are curious or we think something is not looking right, then we're going to do those invasive things next. In the second trimester, we're going to do a quad screen, or also included in the quad screen is maternal serum alpha theta protein screening. This one's done especially if that non-invasive, oh my gosh, I'm blinking, prenatal testing was not done, okay? Maternal serum alpha theta protein screening, if it comes back elevated, that is an indication that we might have some neural tube defects going on in this fetus. If it comes back low, that gives us an indicator that we might have some kind of chromosomal anomaly going on, like Down syndrome or trisomy 18. So either of these two things, elevated or low for maternal serum alpha theta protein screening, would indicate need for further testing to confirm whether there is an anomaly or not. Remember, folic acid or folate decreases our risk of tube defects early in pregnancy, and so we want our patients to start those supplements pre-pregnancy, at least 3 months before, and then during pregnancy continue that folic acid or folate. In the third trimester, we're going to screen again for STIs and treat if it's warranted. And then around weeks 35 through 37, we're going to do that group beta strep swab. Did we talk about that last week or on Monday? Group beta strep. Okay. Group beta strep. Okay. Group beta strep is a normal bacteria that's on everybody's body. And there's a whole slide on this, so you don't have to take too many notes. But group beta strep is a normal bacteria that's on everybody's body. But sometimes it gets around the perineum or around the vagina or the rectum. And during birth, when baby's born, babies can get very sick from it. They can become septic, whereas we wouldn't even know that we had it. So every mama gets tested. They'll do a swab with a Q-tip from their around the vagina, down the perineum, and then around the rectum. We send that swab off to get tested in the lab to see if we have that group beta strep. Okay. If it comes back positive that they do have it, we're going to start penicillin is our drug of choice for this one. Penicillin when in labor every 4 hours until they deliver. If they are negative, there's nothing we do about it. But if they're positive, we're going to do penicillin, our drug of choice, every 4 hours until delivery. We want at least 2 doses of antibiotic or penicillin before delivery to make sure that that baby is covered. If she's allergic to penicillin, it's IV. Mm-hmm.
Okay.
Yep. IV piggyback as a secondary. And that's done if she's allergic to penicillin, lab is going to test to see if that specific type of group beta strep is receptive to clindamycin. That would be our second drug of choice there, or our second line of defense, I guess. And if it is receptive, then we're going to do clindamycin every 6 hours for that one. If it's not receptive to clindamycin, then we're going to pull out the big guns and go with vancomycin. Another slide, which I'll show you guys down the road here. Prenatal visits throughout pregnancy in the first 32 weeks should be monthly or every 4 weeks. Other weeks 32 through 36. And then once per week, weeks 36 to delivery. At every visit, the patient is going to be weighed. We're going to watch her weight and growth. We're going to do a blood pressure check. Sorry about the dogs barking. We're going to dip her urine for protein and glucose. Protein would be a sign of preeclampsia, and glucose a sign of diabetes. And we never know when that's going to start in our patients, and so every patient, every time, gets dipped. We're going to check the fetal heart rate, after heart tones after 9 weeks, when we can actually get the heart tones. And then we're also going to measure the fundal height once we get to that 20 weeks and the fundal height is at the umbilicus. Okay, making sure that that pregnancy is growing properly. Our different non-invasive assessments of fetal well-being during pregnancy. I think we talked about last week doing fetal movement counts starting at 20 weeks. We want them to lie on their side. Which side is it? Do you remember?
Left.
The left side.
Left side, right? And drink a large glass of cold water or juice. And then start counting. We want them to have 10 movements in 2 hours. Any movement counts. It doesn't have to be big kicks. Okay, so any movement counts. 10 in 2 hours. Once they get to 10 movements, they can stop counting, and they're done. If they don't get to 10 in 2 hours, we want them to come in and get checked out. Ultrasounds are non-invasive. We can do them as needed to check growth. We can do an anatomy scan starting at 20 weeks, making sure all of the organs are in the right places and functioning. We can do what's called a non-stress test. If you've watched the electronic fetal monitoring video for lab already, you might know what that means, but there's a whole slide on all of these things, and we'll talk about each one. We can do a contraction stress test and a biophysical profile. What is a non-stress test? A non-stress test is used to determine how well that baby's doing in utero. And it's just simply putting the fetus on the electronic fetal monitor and looking at variations in their heart rate. Why do we do it? Because 2/3 of fetal deaths occur before the onset of labor. And so we want to make sure these babies are doing okay. Otherwise, if they're not, we're going to probably induce labor. A reactive non-stress test means our baby is doing well, and I'll show you what that looks like in just a second here. But that means, if it's reactive, that our baby is doing well 99% of the time. We might repeat that non-stress test twice a week, or maybe every week, depending on what the risk factor is and why we're actually doing this test. Who gets a non-stress test? Our mamas with diabetes, any type. Our hypertensive mamas. If they've had a previous fetal demise, so baby passed away in utero. If they have multiple, or if they have twins, more than twins can't be monitored on the electronic fetal monitor, so we would just do a biophysical profile, which I'll show you in a minute. If they're after their due date, if they're advanced for maternal age is also called geriatric pregnancy, which is kind of rude, right? So we prefer the term advanced maternal age. That is you're considered advanced maternal age once you hit 35 and up. Okay, I know that sounds like geriatric. It's not really, but in pregnancy it is. Okay, so they're higher risk pregnancies. IUGR is intrauterine growth restriction. So baby is growing smaller for some reason. We got to figure that out. The word polyhydramnios or oligohydramnios is referring to the amniotic fluid. Polyhydramnios means there's too much amniotic fluid, and oligohydramnios means there's too little amniotic fluid. So something's causing that to happen. And many, many, many more reasons. On stress tests, we're testing for fetal well-being with this. What we'll do is place monitors on mama's belly with belts. The heart monitor will usually be in the lower position if the baby's head down, or if the baby's breech, it might be placed up high. So we do what's called Leopold's maneuvers, which is in the electronic fetal monitoring video, to determine what position that baby's in. Is it breech, or is it cephalic, or presenting head down? And then we would place the monitor, if you see here, over the baby's back. We can palpate the parts to determine where that baby's back is, and we're going to try to place that monitor right there because that's going to be our optimal heart rate area. Okay. And we want to do those Leopold's maneuvers before even placing the monitors because if we don't know which position the baby's in, we might be searching for quite a while to find that heartbeat, and guess what? That's going to make mama really anxious. And so we want to be sure we know where we're putting that monitor before we're searching for a really long time. Next monitor will go on the firm part of the fundus on the abdomen, and that's a contraction monitor. That monitor has a little button on it, and as the uterus starts to contract, it slowly pushes in that button, and as it relaxes, it slowly releases that button, and it'll draw these mountains on the bottom of the fetal monitor for us so we can see what's going on with that uterus if she's contracting. Up here on this test on this strip is the fetal heart rate. So the top one is going to be your fetal heart rate, and the bottom one is going to be the contraction monitor. The fetal heart rate, we're looking at many different things, which go into detail in that electronic fetal monitoring video. But for this non-stress test specifically, we're looking for 2 accelerations, so 2 increases in the fetal heart rate above their baseline, or the average place where that heart rate falls, in 20 minutes. Okay, so it's a 20-minute test. We want 2 increases in the heart rate in 20 minutes, and that's considered a reactive non-stress test. We know our baby is doing well. It's well oxygenated. If there are not 2 in 20 minutes, then we're concerned, and we're going to do an ultrasound to test for fetal well-being that way. Okay. So non-reactive would be less than 2 accelerations in 20 minutes or no accelerations in 20 minutes. Ultrasounds are used for many different reasons. We can check fetal heart activity. We can check the amniotic fluid volume. We can do a biophysical profile. We can check the placenta location because sometimes the placenta is not in a good spot. Sometimes it's covering the cervix, which could make mama and baby bleed out if the cervix started to dilate. So we can check and see where that placenta is sitting. We can do Doppler flow studies looking at the umbilical cord and seeing how well their vessels are working. We can measure the length of the baby and determine the gestational age. Maybe she forgot what her last menstrual period was, or we would want to confirm if that estimate based on the last menstrual period was accurate. We can monitor fetal growth. We can check fetal anatomy, usually at 20 weeks. This one's done where we're making sure everything's in the right place. And then we can also check fetal presentation. Fetal presentation is referring to what is the presenting part in relation to the cervix. So here in this image, the cervix is over here, the fundus is up here. And so this baby in this image is breech. Okay, so butt is presenting first, but this is a smaller fetus. It's not a term fetus, and so it's okay. So a lot of times they'll start breech the whole pregnancy, and then as they get closer to their due date, they'll make a turn to go head down most of the time. So remember, fetal presentation is not testing for fetal well-being. Fetal presentation is looking at what's that presenting part in relation to the cervix. Okay, how is that baby going to present first? This is amniotic fluid index. They would imagine dividing the abdomen into 4 quadrants, just like we do for bowel sounds, right? And then they're going to scan and measure the deepest pocket of fluid in each quadrant. Then those totals get added up, and that's how they can determine if their amniotic fluid is normal, or if it's low, oligohydramnios, or if it's too much, polyhydramnios. The biophysical profile. Part of this biophysical profile includes that non-stress test. That's why on that image here, you can see the fetal monitor here. So they would do that non-stress test first. If they got 2 accelerations in 20 minutes, then they get a 2 on their score for this test. I'm going to zoom in here for you guys so you can see. Oh, that's zooming in on the... Let me maybe try here. Why can I not? Ah, there we go. Okay. What else are we looking for besides heart rate and that non-stress test that goes here? Okay, there are 5 categories that we're looking at. We're looking at their breathing. Are they practicing breathing? They're not using their lungs, but they should start practicing breathing in utero. If they, this is actually wrong on this slide, if they have 1 breathing episode within 30 minutes, that gets a score of a 2, okay? If they have no breathing episodes in 30 minutes, that's abnormal, and that would get a 0, okay? So it's either 2 points or 0 points in this one. Are they moving? Are they are they moving at all in utero? 2 or more movements in 30 minutes gets a 2 score. Less than 2 gets a 0 score. Muscle tone, they're looking at, is that baby bringing their arms and legs into their chest in that fetal position? That's good muscle tone. That would get a 2 score. Or are they not well flexed? That would get a 0. And then finally, amniotic fluid. They would do that amniotic fluid index, and if the amniotic fluid is normal, they would get a 2. If it is not, then it would get a 0. So our perfect score would be 10, right, on the biophysical profile, looking at these categories. Don't worry about scoring so much. I want you to know these categories. So what are we looking at? We're looking at fetal breathing. We're looking at their movement. We're looking at their muscle tone. We're looking at their heart rate via a non-stress test. And we're looking at the amniotic fluid volume. We'll put all of that together to determine fetal well-being. If they don't have a perfect score, we might consider induction. Or if they're really preterm, we might start to mature their lungs using some medications that we'll talk about next week. And then probably induce, but watch that baby closely. Invasive testing happens only when we have an abnormal result on blood work. Okay, so either the NIPT test, non-invasive prenatal test, was done in that first 5 to 8 weeks and it came back abnormal. That suggests that there's chromosomal anomalies in that baby, okay, in that fetus. So we would do invasive testing to confirm if that's the case. Doesn't mean 100% it is, but it puts that fetus at higher risk. So we would do invasive testing to confirm. Or if the maternal serum alpha theta protein screen came back abnormal, remember elevated means that there's suspected neural tube defects. We don't know what, could be spina bifida, could be cleft lip or palate, we don't know. Or if it's low, then we have a risk for Down syndrome, trisomies, some kind of chromosomal anomaly. We'll talk about each of these invasive testings. I'm going to start with, I have both of these on here, amniocentesis and chorionic villus sampling. Chorionic villus sampling is done earlier in pregnancy, so that NIPT test came back abnormal. We could do this testing to test for the chromosomes on the fetus. What they would do is go in vaginally and aspirate some of the cells from the placenta. And then they would send that off to the lab. It's ultrasound guided. You can see the ultrasound monitor is up here. And then vaginally, they're going to aspirate some of those cells with a needle. Then we send those fetal cells off to the lab, and it's going to look at karyotyping, or the chromosomes of that fetus, to determine for sure if there are chromosomal anomalies. With a CVS test, we can do that earlier in pregnancy. Okay, it's done usually within the first 11 weeks. And the results come back very quickly. So if there was a major chromosomal issue, the parents could determine if they wanted to abort that fetus earlier rather than waiting. Okay. Actually, it depends on your state whether you can choose to abort for chromosomal anomalies. And in the state of Arizona, it is illegal to choose to abort currently for chromosomal anomalies. Later on in pregnancy, we can do an amniocentesis. Amniocentesis can't be done until about 15 to 20 weeks pregnant. Okay, so that's why we would do a CVS because we could get those results quicker, and we can do it sooner in pregnancy. But if we didn't know, we missed that NIPT test and our maternal serum alpha theta protein screen came back abnormal, then we can do an amniocentesis about weeks 15 to 20. The way we do that is we use an ultrasound again to make sure that we're not going to hurt the fetus. It is a risk, but then we insert a large needle into the amniotic fluid through the uterus and aspirate the amniotic fluid. That's going to have fetal cells in it, and we can determine the chromosomes on that one. That gets sent off to the lab, and it takes several weeks to get those results back. So it might be too late, depending on the state that you're in, to determine if you wanted to abort or not, or depending on the abortion rules in your specific state. So know the difference, why we would do CVS versus amniotic or amniocentesis. we would do CVS earlier in pregnancy, and if we missed that CVS window, we would then do an amniocentesis. This is just a larger image of amniocentesis. Remember, it's ultrasound guided, and we would aspirate the amniotic fluid. Now, we can also do an amniocentesis in the 3rd trimester to test the amniotic fluid to see if the fetal lungs are mature. If the fetal lungs are mature, then there will be surfactant in there, and surfactant will tells us if the fetal lungs are mature. And then we could induce if needed, or if they're immature, we can give medications to help get them to mature quicker. This is PUBS, percutaneous umbilical cord sampling. And I can put that in the chat there. Although it did spell it out on our screen here. Morris, do you have a question?
Yes. I just wanted to we give surfactant to mature the lungs, right?
We would give different medications, which we'll talk about next week. It's betamethasone. It's a steroid to mature the fetal lungs. Yeah. Okay. Percutaneous umbilical cord sampling is where we would, again, ultrasound guided, insert a needle into actually the umbilical cord of the fetus. We could then send that blood sample off to do like a CBC. This is really why we would do it, to test for fetal anemia. Sometimes some mama's blood types will attack the fetus or the fetal blood cells and cause the baby to be anemic. And the reason for that is in the end slide. Or if we do get the result back that the baby is severely anemic, then we can also do a PUBS to transfuse the baby in utero. Okay. So either way, we could aspirate blood and send it off for a CBC, or we could, even if needed, we could transfuse. If the babies had, maybe you had twins, right? And we have one baby taking more oxygen and nutrients from the other. That's called twin-to-twin transfusion. We could give the other baby back some blood that way. Glucose testing is done between weeks 24 through 28 gestational age. Or if the patient is high risk for gestational diabetes, they're going to do that glucose testing right away at the first prenatal visit. Every visit, we do a urine dip for glucose, but we're going to do a glucose tolerance test, or GTT, between weeks 24 through 28. So wherever her prenatal visit falls in those weeks is when they'll send them to do this test. What they do is they go to a lab and they'll do their first screening. The first screening, they're given, if you can see the background, they're given a very sugary glucose drink that typically has 75 grams of carbs in it. Very, very sugary. They need to drink that drink pretty quickly. And then 1 hour after that test, they're going to test mama's blood and see what her glucose level is. With this first screening, they can be fasting or non-fasting. It doesn't matter. However, some labs might say that you have to be fasting. Just depends, but most of the time, fasting or non-fasting. And then 1 hour after that drink, we'll test the glucose, and if it's greater than 140, that's abnormal. Okay. If it's greater than 140, the provider is then going to send her another day because it takes a while to get this result back. It's not just a finger stick, it's a blood draw. If it's abnormal, then the provider is going to send them for a 3-hour glucose tolerance test. Typically, again, depending on the lab, it's now a 100-gram sugar drink, grams of carbs drink. They're going to come in fasting for this one. Okay, they're going to draw their blood fasting first. A normal fasting level is below 92 for a pregnant woman. That's what we're looking for. She's going to drink the drink quickly. And 1 hour after the drink, we're going to draw her blood again. We want less than 180 and the result there. 2 hours later, they're going to draw her blood again. We want less than 153. 3 hours later, we're going to draw her blood one more time, and we want less than 140. Okay. Know the range for the first one. If it's abnormal, know that we're going to send, if it's greater than 140, we're going to send her for the 3-hour. And in order to determine if they have gestational diabetes, 2 of these values need to be abnormal. Okay, so 1 might be elevated, but 2 of them have to be elevated in order for her to be diagnosed with gestational diabetes. If 1 is elevated, she's not diagnosed, but we still keep an eye on it because she does have higher glucose levels, and we could have a larger baby because of those higher glucose levels. Okay. That slide talking about group beta strep. And it tells you all of the things that we talked about. It's just the culture that goes around the vagina, down the perineum, and around the rectum. Our drug of choice is that penicillin G every 4 hours until delivery. Luis, 2 levels, going back here, Luis was asking it needs to be elevated above 140. That's just for this one here. Then they get, if it's above 140, they go to the 3-hour. And if 2 of these are elevated, then they're diagnosed. So say their fasting was 92 or 90. Their 1 hour was 190, and then their 4 hour was 150. They would then be diagnosed with gestational diabetes. So 2 have to be off. Okay. Why do we care about group beta strep? Because that bacteria can make our newborn become septic when it's birthed, okay? And it doesn't matter if it's birthed vaginally or via C-section. We would want to get some antibiotics on board before delivery. If we give antibiotics, about 1 in 400 will be affected by this group beta strep. If we don't give it, about 1 in 200 newborns will become septic. And so it's really important that we get those antibiotics on board before delivery. I think Queen had a question. No?
I'm sorry.
Did
My
I say
internet is, yeah,
that's okay.
it's going in and out. I'm sorry.
No, you're okay.
So just the gestational diabetes, does that go away after birth, or does that continue on as she's diagnosed with? Okay.
Yeah. So once the placenta is delivered, it's not giving off that human placental lactogen anymore, which causes mom to be insulin or resistant to insulin on purpose, right? To make that baby chunky and start to get some fat before birth. And so once that placenta is gone, then they don't have that hormone. It's not immediate, but it does flush out. RH incompatibility is a process where if the mom's blood is RH negative, it can possibly, and at some point the blood mixes, it can possibly attack the next fetus's blood. You guys have slides here just for notes for studying, but I'm going to play the video for you because she does a really wonderful job of explaining these things. Let me know if you can't hear.
Hi everybody, I am that nursing prof and welcome to my channel. In today's video, we're going to be talking about RH incompatibility. So let's get into it. So the first thing I want to describe is, well, what is the RH? What is that about? So it's a protein found on the surface of your red blood cells. So if you have that protein, you're RH positive, and if you don't have it, you're RH negative. So an example of this would be, you say your blood type is O positive. So the positive is the RH, or O negative, then you don't have it. So that's where this comes into play. So this whole thing is a big issue when moms are RH negative and the fetus is RH positive. If you are an RH positive mom, then this does not concern you at all. This is not an issue. This only concerns women who are RH negative. So our big concern is isoimmunization. So for that to occur, the fetus must be positive and the mom must be negative. There needs to be at least 0.1 ml of fetal red blood cells that enters mom's circulation. And now that can happen at any time during pregnancy, labor, delivery, postpartum, but 9 times out of 10, it will happen during labor after the placenta has separated. And then 3, mom must produce anti-D antibodies. So mom's immune system has to be strong enough to make these antibodies. So basically what's happening is, think of like an allergic reaction, okay? So your body is being exposed to something, it's never been exposed to it before, it recognizes it as foreign, but it doesn't necessarily do anything about it, it just goes, I'm gonna remember you, I'm gonna remember you. And then the next baby happens, and it's RH positive, and the body goes, oh, I remember you from before, you don't belong here, I'm gonna destroy you. Okay, so think of it as a reaction like that. So the first pregnancy, nothing happens. She produces the antibodies, but nothing happens to her, the baby. Subsequent pregnancies, mom's body will attack baby's body because they don't match, because it looks like foreign, okay? So this is an issue for subsequent pregnancies, and antibodies can cross the placenta. So in the first pregnancy, she's making the antibodies. So they're not going anywhere because she's making them. In subsequent pregnancies, she already has those antibodies and they can cross the placenta and cause harm and even fetal death to the baby. And that's our biggest concern here, is we don't want that to happen because women can't help it if they're RH negative or positive, right? So obviously we don't want this to happen, right? We want to prevent this, and we want the woman to have a healthy pregnancy and have a healthy baby. So there are things we can do to prevent it and tests we can do so that we can detect it. Now let's talk about RhoGAM. So RhoGAM is what we give to our RH negative moms to prevent isoimmunization from happening in the first place. So RhoGAM is made from human plasma. All of my students at the beginning of my OB class, I give them a med list, and I always put RhoGAM on the list, and I always make a point to say, RhoGAM is not a medication. It is actually made from human plasma. It is a human blood product. So you're not probably going to find it in your drug book, but it is very important, and it is given via IM injection. Something you need to keep in mind about this as well, if your patient has cultural considerations or religious considerations where they do not want blood products or they refuse that kind of things, you need to know that about them, okay? Because this is one of those type of things. So it's made from human plasma. It works by coating and destroying any fetal red blood cells that have made their way into mom's circulation. And I know that sounds like, oh my gosh, we're destroying the fetal red blood cells. But these are the ones that are in mom's circulation. This is not going to hurt the fetus at all, okay? So this does no harm to the baby. Its whole goal is to prevent something called erythroblastosis fetalis. So basically what that is is mom's been sensitized, right? The isoimmunization has happened. She's been sensitized. Her body's made the antibodies, okay? So it's preventing the antibodies from then going and attacking and causing hemolysis of the baby's red blood cells. Because if we did absolutely nothing and this occurred, it would kill the fetus. It would kill the baby. And we don't want that to happen, right? So the whole point of this RhoGAM is to prevent this from happening. When do we give it? So we give it to all moms at 28 weeks. We give it within 72 hours after delivery if baby is Rh positive. After any bleeding episodes, so this could be minor bleeding like spotting, this could be major things like placenta previa or an abrupto placenta, whatever, it doesn't matter. If mom is bleeding at all during pregnancy, she's getting a RhoGAM. Sometimes we do testing on these women that might cause some bleeding. So if we do something like an amniocentesis, she might need to get a RhoGAM after that. And then also after spontaneous abortion, miscarriage, moms need to get RhoGAM. And I guarantee you that is an NCLEX question. So Rh negative moms absolutely need to get a RhoGAM after miscarriage or elective abortions.